Hello, everybody. Welcome to Grand Rounds. Delighted to have you with us. And we welcome as our special guest today, Dr. David Steiger, somebody who needs no introduction, and yet I feel like deserves an introduction, both because he's such an important part of the Beth Israel community, and because he's been such a force both locally and on the national scene in terms of pulmonary and critical care medicine. He's been a pulmonary and critical care physician for 30 years, including 21 years at NYU and 8 or so years in the Mount Sinai health system. He's, of course, the division lead for pulmonary and critical care, both at Beth Israel and at Mount Sinai West. He's a leader in thromboembolic disease, in COVID-19 and COPD. In QI work, it's led to, among other things, the Pulmonary Embolism Response Team, which was founded here at MSBI in 2015. He's got more publications and presentations than I can count. He's been awarded Teacher of the Year many times, serves on a number of committees with CHEST, the National Pulmonary Organization, and is just a delightful person to call a colleague. And so I welcome Dr. David Steiger.
Oh, God. Matt, first of all, thank you so much for those very kind, generous words. And now I'll mess up everything, and you'll have to eat your words. And Miranda, thank you so much for the invitation as well. It's really nice to play to the home crowd, so to speak. So no curveballs, right? Okay, so let's start. So here's a brief overview. So I'm going to discuss and share with you many facets of the management of patients with pulmonary embolism, with a focus on introducing current concepts, guidelines, and new literature. But in exploring the different facets of PE management, let me talk you through where we're going. We're going to talk about advanced therapies, and we'll talk about mechanical thrombectomy. Many of you who follow PE patients will know that it's now the treatment du jour. And I'll talk about the indications for it and why it may be advantageous. And the FLASH registry is the largest retrospective analysis of consecutive patients who've had this procedure. In the absence of randomized control studies comparing conventional treatment versus advanced therapies, including catheter-directed thrombolysis, we just don't have enough double-arm studies. I'm going to resort to a meta-analysis and come up with some conclusions on the benefits of catheter-directed thrombolysis. I'm then going to talk about management of patients, including clinical signs, the heart rate. How important a prognostic factor is the heart rate? And I'm going to show you something which is really quite simple, but really quite powerful. And then we're going to examine the role of the PE response teams. Do they work? Does it change length of stay? Does it decrease mortality? There's a paucity of evidence, but let me show you a recent study from 2022. And then we'll be talking about length of stay. It's not often we talk about length of stay in PE patients, but here's an excellent paper and a management pathway, which I recommend we could adopt in normotensive patients and decreasing length of stay. No grand rounds would be full or complete without introducing artificial intelligence. And indeed, it's impacting the way radiologists do their work. And I'll be giving you an update on use of artificial intelligence and in patients with suspected PE and what we're actually doing at NYU right now. And just as importantly, if not more importantly, shine a light on racial disparities and outcomes, specifically here looking at patients who present with acute PE. And I will show you from this study that unfortunately Black patients who present with PE often have more severe PE and are denied the kind of advanced therapies that many centers can provide to non-Blacks. And then finally, across the continuum of care, we'll look at outpatient management of PE. And this is a really nice paper, which I'll show you from the American Society of Cardiology. And it's something that I think would be instructive for all of you who see PE patients post-discharge. And it focuses on 5 or 6 main pillars of management. And if we have time, I'll talk about this increasingly observed phenomenon that our PE patients up to 1 year later may still have persistent PE. What does this mean? And I can't answer that question. But before we look at the recent literature and look at, first of all, catheter-directed thrombolysis, I really want to set the table and talk about risk stratification and prognostication and highlight why things are problematic when patients come with intermediate risk PE. So the overall mortality for PE patients is 13%, which may be an underestimate because patients die at home and they die in nursing homes of silent pulmonary emboli. For patients who present with high risk PE, those who are in shock, the mortality rate is at least 30%. For patients who coded, it's at least 70%. The vast majority of patients who preoccupy us in the hospital are those at intermediate risk, have RV dysfunction, where you see there's quite a range of mortality from less than 2% to 17%. We'll be examining why and understanding the challenges, determining what is the optimal management for these patients. Low-risk patients, they are responsible for at least 2/3 of patients who come to the ER with a PE, and many of whom can be safely discharged within 24 hours. All of you are familiar when a patient comes to the ER, we risk stratify them in many ways, including using the PESI score. And the PESI score collates both demographic and clinical, including past medical history factors. And in summation, you can stratify the patient to one of 5 classes. And if a patient's in class 1 or 2, they have a, quote, low risk, unquote, of death at 30 days. And in addition and in parallel, we will risk stratify patients using the European Society of Cardiology and European Respiratory Society risk stratification scheme. Patients at high risk are those in shock. Those at intermediate risk have RV dysfunction. They're intermediate high if they have both elevated biomarkers and RV dysfunction on echo and or CT. Intermediate low is where these patients have RV dysfunction and advanced PESI, but they either have biomarker elevation or RV enlargement. Those at low risk are those who have no biomarker elevation, they don't have RV dysfunction, and they're hemodynamically stable. What do we know? Well, we know that if the RV to LV ratio is greater than 0.7, it's associated with increasing mortality. And we know that the biomarkers we use, the troponin and the BNP, elevations in those specific biomarkers correlates with RV dysfunction and also is associated with increased risk of mortality. But here's the problem. So the positive predictive value of an abnormal CT angiogram, elevated BNP, elevated troponin is not great. And this is why in the next minute or two, I'll look at newer techniques of risk stratifying patients. And that's important because a few slides ago, I showed you the intermediate risk patients where the risk of death is from 2% to 18%. These studies are not really helping us and predict which patient is at risk of dying. What tools can we use to increase the positive predictive value of the studies we're using? The BOVA index, which I'll define in a minute. Plasma lactate, just as in sepsis and acute MI, elevated plasma lactate is associated with the worst mortality. This will be increasingly used. It's called the FAST. It's an acronym for, first of all, fatty acid binding protein, that's the F, and then syncope and tachycardia, and has a very high positive predictive value for mortality at 1 month. And then this is something which intuitively we understand. If you're elevated, if your PESI is elevated, your biomarker is elevated, and you have a concurrent DVT, that's associated with worse prognosis. This is the BOVA risk score, and many of you are familiar with it, and it integrates borderline blood pressure, elevated biomarker, elevated heart rate, we'll get to that in about 10 or 15 minutes, and RV dysfunction. And we know that if you're in class 3, your risk of in-hospital P-related complications and P-related mortality is highest, 8.8%. So here's a case I'm going to present to you. This is a 48-year-old female with protein S deficiency. She knew she had protein S deficiency because her mother had recurrent VTE at a young age that prompted her kids to be tested, including this patient, who was found to have protein S deficiency. She was not on any DVT prophylaxis except for an aspirin, which is not evidence-based, but had no prior DVT or PE. She had returned from a flight from San Diego and then took to bed because she had COVID. No, let's not say COVID, that unnecessarily complicated, let's just say an acute viral illness, a non-smoker, and borderline blood pressure, tachycardia, requires oxygen, tachypneic. Exam was benign, troponins elevated, and lactate was not elevated. So first of all, here is So you can see both. Here's the main pulmonary trunk, divides into the right and left main pulmonary artery, and you see a large clot burden in the right main pulmonary artery and left main pulmonary artery. So this is a central clot. And this is another image, axial image of the CT scan, and it shows an increased RV to LV size. And here's the echocardiogram, apical 4-chamber, and it shows the following. You see this patient has McConnell's sign. The apex is moving, but the main free wall of the right ventricle barely moves. And that's because the RV is under enormous pressure from the high pulmonary vascular resistance from the pulmonary embolism. So you have an RV dyskinetic. And in addition, you have the D sign. So the LV has the interventricular septum creates this D shape, which is a manifestation of a volume and pressure overloaded right ventricle. So this patient is sick. She may be on the precipice. So we have choices. And I'm going to use this grid as a platform to discuss the recent literature. Conventional anticoagulation, systemic thrombolysis, catheter-directed therapies, surgical embolectomy, and ECMO. Let's go through each one very briefly. Systemic anticoagulation is just not good enough. We can start it immediately. Low molecular heparin has a better bioavailability than a fractionated heparin. But unfortunately, in patients at intermediate and high risk, there's a high failure rate. Systemic thrombolysis is recommended if patients are in shock and there's no absolute contraindication to it. And we do know that there's almost immediate improvement in RV function, decrease in pulmonary arterial pressure, and decreased pulmonary vascular resistance, but a significant risk of major bleeding with a risk of intracranial hemorrhage at least 2 to 3%. And hence, for the last 10 years approximately, we've been focusing on catheter-directed treatments in patients at intermediate and high risk. And it comes in different forms, and we'll be examining a percutaneous thrombectomy. The rationale is you can use lower dose of thrombolytics, particularly the ultrasound-assisted thrombolysis, which we occasionally use, associated with significantly less bleeding than systemic thrombolysis. Surgical embolectomy used to be reserved just for patients in extremis, but now it can be, and patients who failed thrombolytics, but now we use it more aggressively in patients who are deteriorating rapidly, perhaps like this patient, if they continue to deteriorate, and increasingly use it for intermediate risk patients where thrombolytics or even catheter-directed thrombolysis may be contraindicated in recent patients, perhaps post-neurosurgery or spine surgery. And we won't spend the next 50 minutes talking about vena cava filters. That's for another time. So catheter-directed thrombolysis, it works in that it improves hemodynamics, as mentioned, decrease in pulmonary systolic pressure, improve RV to LV ratio, and decreases the Miller index, which is an expression of clot burden, with lowish mortality rate and less bleeding, major bleeding compared to systemic thrombolysis. And if we look at 3 main studies examining the role of catheter-directed thrombolysis, each of them show that there's a significant reduction of pulmonary arterial pressure within 24 to 48 hours. So let's talk about catheter-directed thrombectomy, which many of you who manage our patients with PE will witness are being increasingly, this technique is increasingly used. So what is it? Unlike catheter-directed thrombolysis, there's less risk of bleeding because we don't use thrombolytics. It was first described in 1993, and CHEST recommended that it should be indicated for patients who are in shock, at high risk of bleeding, and failure thrombolysis. But as you're well aware, we are using it increasingly in patients at intermediate risk PE. So what does it look like? So either via the common femoral vein or the right IJ, the interventional radiologist inserts the needle through it a wire, and over the wire, he or she will insert this aspiration guide catheter, which will be guided to the site just proximal to the site of the clot on the pulmonary angiogram. And then the radiologist will insert through the aspiration guide catheter here, this catheter, and then open up these discs. And how does it work? So here's a pulmonary angiogram in a patient who has a right lower lobe and middle lobe pulmonary embolism. You see significant oligemia compared to blood flow to the right upper lobe. And here you see the catheter being introduced and the discs inflated, and the catheter is pulled back, and then you see clot removed and improvement in blood flow to the middle lobe and lower lobe. And a previous study in 2019 showed a decrease in RV-LV ratio, decrease in mean arterial pressure. So this paper came out last year, and it showed the safety and efficacy of the first 250 patients who received mechanical thrombectomy, looking at major adverse events, and secondary endpoints include changes in hemodynamics, cardiac function, and heart rate. And of the 250 patients, most were intermediate high risk, 85%, 6.8 were high risk, and the RV to LV ratio mean was 1.5. So these patients had significant clot burden. And I show you these two tables for the following reasons. Number one, ICU length of stay 0 days. It was actually part of a day, and the hospital length of stay was 3 days. So that's pretty impressive for patients at intermediate high risk who are having this procedure, with no mortality at 2 days and 0.4% mortality at 30 days, with improvement in hemodynamics, a decrease in PA pressure, pulmonary vascular resistance, improvement in cardiac index from the LV output from decrease in pulmonary vascular resistance, hence improved filling of the LV, with improvement in the RV-LV ratio and decrease RV systolic pressure that has to be generated to overcome the high pulmonary vascular resistance, with improvement in RV systolic function and RV dilatation. So in summary, the largest case series of consecutive patients who received this technique, which is a technique that we use here in our intermediate and high-risk PE patients, improvement in RV size and function with low complication rate. And many of these patients of relevance had contraindications to thrombolytics, hence this procedure was indicated. Unfortunately, there are no direct comparisons of this technique, catheter-directed embolectomy versus thrombolysis, but we see with embolectomy there's an early improvement in hemodynamics, comparing studies with minimal use of the ICU. But it's not it was a single-arm study. This is the same patient after catheter-directed embolectomy, and you see the RV is much smaller. The septum isn't bulging into the LV, and the RV free wall is now moving. So that's a nice result. So as I mentioned, in the absence of randomized control studies comparing that technique, for example, or catheter-directed thrombolysis versus standard of care, we have to resort to meta-analysis. This is a meta-analysis that came out last year comparing catheter-directed thrombolysis versus standard anticoagulation. And it's based on 12 studies, 11 were observational, and 1 was a randomized control studies. Most patients received systemic anticoagulation versus 1,800 who received catheter-directed thrombolysis. So these are the 11 studies. Most of the patients who received catheter-directed thrombolysis had ultrasound-assisted catheter-directed thrombolysis. This is a technique which uses very low amounts of TPA, about 4 or 8 milligrams over 16 to 24 hours. And follow-up was variable from no follow-up to 1 month to 12 months. And what did it show? That compared to conventional treatment, and this is why we have PERT to discuss these issues, compared to conventional treatment, admittedly not in randomized control studies, but based on meta-analysis, catheter-directed thrombolysis decreases in-hospital mortality, 30-day mortality, and 90-day mortality compared to systemic anticoagulation, with improvement in RV, but no change in length of stay, no change in major bleeding, no change in minor bleeding. So in summary, the technique is associated with lower mortality on meta-analysis, admittedly, with improvement in RV function with similar rates of bleeding and length of stay. It's not a randomized control study. Indeed, the only randomized control study comparing catheter-directed thrombolysis versus unfractionated heparin is this study, which at 24 hours demonstrated significant improvement in RV-LV ratio and PA pressure at 24 hours. There is an ongoing randomized control study. This is the first one to compare ultrasound-assisted catheter-directed thrombolysis versus systemic anticoagulation. Let's move on. How important is it to us as clinicians when our patient with a PE has an elevated heart rate? We know that the elevated heart rate, we know in terms of prognostication that low-risk patients we can triage and send home early and higher risk may benefit from advanced therapies. And we know PESI score, which I showed you at the beginning, incorporates amongst blood pressure, respiratory rate, and temperature. It also incorporates an elevated heart rate in terms of risk stratifying the patient. And we use an elevated heart rate in BOVA and this new risk assessment tool, which I mentioned. So we know it's useful as a prognosticator. But let's look absolutely at admission heart rate and outcomes. And this is based on the RETI registry, which is a multi-site registry, consecutive PE patients admitted throughout Europe over 20 years, 44,000 patients. So they looked at 30-day all-cause and PE-specific mortality. First of all, let me guide you through the study. In general, if your patient had an elevated heart rate, 120 to 140, or greater than 140, the patient was older, greater risk of being female, and a significantly greater risk of having a prior VTE, cancer, recent surgery, a greater risk of having comorbid conditions, chronic lung disease, heart disease, a greater risk of having borderline blood pressure and elevated heart rate, and decreased O2 sat. So these patients are sicker and they're older with an elevated heart rate. And most importantly, when it came to outcomes and mortality, 30-day all-cause mortality and 30-day PE-related deaths were higher in patients with an elevated heart rate, 120 to 140 or greater than 140. And they analyzed results in three ways, both unadjusted, where that trend continued, increasing heart rate, increased odds ratio of mortality, or using different models, unadjusted, adjusted for age and sex, and adjusted for covariates, including multiple morbidities. So quite simply, you could express results as follows, with heart rate as a continuous variable. Both 30-day all-cause mortality and 30-day PE-related mortality increased as the heart rate increased. Another way of looking at it, as your heart rate declined, the mortality rate declined as well. So I think I showed you convincingly that elevated heart rate is associated with increasing 30-day PE and all-cause mortality. What is it telling us? Well, we know physiologically that if you have a high clot burden, your pulmonary vascular resistance is high, and therefore the ability of the RV to empty and fill the left ventricle declines. So our cardiac output declines. So how do we compensate for a decreased cardiac output? We can't increase the stroke volume because we can't fill the left side, so we increase heart rate. So that's what we're seeing. We're seeing a compensatory response to decreased filling of the left ventricle to try and maintain cardiac output. So we should be looking at a heart rate perhaps more with greater discrimination and using it as a positive predictor. The problems of this study, it's not clear from those 44,000 patients when the heart rate was recorded. The assumption was that it was on arrival. And there was no allowance for whether or not these patients were on rate controlling drugs, calcium channel blockers, beta blockers. So let's move on. And let's talk about PERT teams. We've had PERT teams that Dr. Weissman said here since 2015. And I think they're very successful because, well, I'll get to that in a minute with the next slide. So we know at least 200 to 400,000 patients are diagnosed with PE in the United States each year. And we know that's an underestimate, and we risk stratify them. And we have a multidisciplinary PE response team to try and in real time, multiple disciplines come together and try and reach a consensus and recommend the optimal method of treating these PE patients. We are members of the PERT Consortium since 2015, a national organization. There are over probably 200 PERT centers now worldwide. And the reason why we have a PE response team, as I've mentioned, is we have many choices in treating patients with advanced PE, but there's a paucity of literature in guiding us as to what is the optimal treatment. Unlike our stroke teams and trauma teams, ACS teams, where we follow evidence-based guidelines. Well, there's a paucity of literature looking at outcomes from PE, and I'm going to show you two studies before I show you the most recent study. And this is study number 1, and here are the headlines. They had about 770 PERT patients managed pre and post-PERT. And they showed that in the PERT era, there was less bleeding, decreased time to initiation of anticoagulation, decreased use of filters, and increased use of thrombolytics, but that was not significant, and a decreased 30-day mortality. So this study suggested that in the PERT era, use of PERT is associated with decreasing mortality. By contrast, another study from 2 years ago, and where it compared outcomes in patients managed pre-PERT and then during the PERT era, it showed no difference in PE mortality. So here's a study from one of our best respiratory journals from 2022, 16 studies, about 8,000 patients. Admittedly, 3/4 of the PE patients were not high risk, which may be a problem in take-home message. And the idea of the study was to look at outcomes and specifically what effect did the PERT team have on advanced therapies, including open embolectomy and ECMO, and outcomes, bleeding, mortality, readmission. You might hypothesize that the use of PERT is associated with decreased mortality and maybe decreased length of stay. So what did it find? Let me summarize from these forest plots. Number one, advanced therapies increased during the PERT era. Now, it may not be just because of PERT, because a lot of these therapies became available at the time that PERT became available. And those two factors are associated, because I think the need to establish a PERT team was based upon the fact that we had increased advanced therapies in terms of our palette of choices to give our patients. Less use of filter placement, bleeding complications were similar. There was no significant difference in mortality pre versus post-PERT era. There were more cath-directed interventions, less use of filters. So in this study, it did demonstrate in the PERT era we use more advanced therapies, and I think it's no coincidence, but I think it's by association, as I mentioned before. And there was less use of filters placed, because I think we've become increasingly, we increasingly understand that filters need to be retrieved. They're associated with long-term complications. They can migrate even in the short term. I think if we can agree on any one thing, inferior vena cava filters should be inserted in patients who have absolute contraindications to anticoagulation. There's a trend towards improved mortality with implementation of PERT with similar bleeding complications, maybe because of less use of thrombolytics and greater use of cath-directed interventions, which use a lower dose of thrombolytics. But length of stay did not change, and we'll be talking about length of stay in a minute. So this is a problem because all the different studies had differences in the quality of reporting bleeding complications, both minor and major. And it included 3/4 of these patients were low-risk PE, and you would agree that the PERT team probably has little to add when invited to take care of low-risk patients. And I don't think we're going to have a randomized control study of PERT managed versus standard of care evaluation. So let's talk about artificial intelligence. This is a really interesting paper, and it has a happy conclusion, because I'm not prognosticating the loss of employment of radiologists, but I am providing evidence for, quote, the augmented radiologist, a radiologist who can work alongside artificial intelligence for our benefit, for the patient's benefit, for the radiologist's benefit. Why is there a need for artificial intelligence in interpreting pulmonary emboli? A hell of a lot of CT angiograms are ordered every day in the Mount Sinai health system, with more images, a lot of work to be done by the radiologists, who are suffering, like all of us, increasing burnout and potential risk of errors. And what do we need in this disease state? We need an early and reliable diagnosis so we can start anticoagulation early, because we know that's associated with improved outcome. Unfortunately, CT angiograms are notorious for being often inadequate in up to 25% of cases. Suboptimal opacification and image interpretation may be problematic where there are clots that are not pulmonary emboli, but are mimicked. PE are mimicked by a fat embolus, amniotic fluid embolus, air, metastatic disease, etc. So this is a study from European Radiology, and it compared the diagnostic accuracy of humans, ourselves, radiologists, versus AI detection of PE using a CT angiogram. So you may ask, what is the gold standard? Well, it's not AI. The gold standard included a senior radiologist who read CT angiograms every day, and an expert in AI who also had access to clinical radiological data as well as the radiologist. And it was a consensus of these two, a radiologist and an AI expert. These are consecutive patients, a large multi-center study done in the ER, patients admitted with a rule-out PE. And how are they interpreted? I'll show you how they were interpreted. They were interpreted as per usual by radiologists, and then also interpreted using an AI algorithm. Okay, the slide on the left is the conventional diagnosis, the blue arrow here of a left lower lobe pulmonary embolism. And here on the right, by artificial intelligence using different kind of highlight, they automatically can diagnose and identify a PE in that same area. It looks very different, but concordance. So what is the outcome? How did the performance of AI versus radiology? So green is AI and blue is radiologist, teleradiologist, not trusted radiologist, teleradiologist. So let me give you just an overriding conclusion. Number one, AI is more sensitive, but radiologists have greater specificity and negative predictive value and overall greater accuracy. However, I mentioned that up to 25% of CAT scans may be poor quality. This is the advantage of AI, and you see how the greater sensitivity in diagnosing PE in patients with sub-quality CT angiograms. And this is an important study. There was a results. This is results showing the discordance between AI and radiologists up to 7.1%. Less discordance between AI and gold standard, as you'd imagine, because these were experts in use of interpreting AI results. And here, ominously, up to 10% of studies were not captured by the radiologists, but captured by AI. So in summary, versus radiologists, AI confers higher sensitivity and negative predictive value, although the differences were not that significant compared to radiologists. And radiologists are superior with improved specificity, positive predictive value, and accuracy. The overall AI sensitivity is 92% with a high specificity. Problematically, AI diagnosed 1.5% of cases that were missed by a radiologist. And importantly, the radiologists said they were highly satisfied with using AI. It is a retrospective study, and perhaps studies should be done in real time with the radiologists and looking at accuracy as a function of hours of day on call and volume of studies that need to be read. But what the study suggests is that the augmented radiologist, the radiologist who has access to AI, particularly for poorer quality images, can enhance the sensitivity in diagnosing pulmonary emboli. So again, the augmented radiologist, not the replaced radiologist. So within the Mount Sinai system, the following is being developed and will be hitting real time soon. And the idea here is that we already know, and you've probably seen the reports, that if a PE is diagnosed initially by AI, and then a human, a radiologist, a resident at night, and then an attending at night or an attending during the day, will confirm, agree or disagree with the AI interpretation. So here, unilaterally, the AI is diagnosing a PE, and then we'll incorporate some data. So as follows. So eventually we will have this app. A number of apps are being looked at right now. This is somebody with a central pulmonary embolism, a saddle embolism, a right and left main PE. This is appearing on our phone. And this application is bringing in the cuts of the heart, looking at RV versus LV diameter. So this is somebody with a central clot and RV dilatation, increased RV-LV ratio, and also is putting in the biomarkers, the D-dimer, all of it on our phone automatically. So it's very powerful, and telling us that the echo is pending, actually was performed until was a Doppler study. And so that's amazing information that we could have in our phone automatically. So let's just move on, and a new section now, and looking at health outcomes in patients with pulmonary emboli, specifically looking at the role of ethnicity and outcomes. Unfortunately, we well know that there are significant disparities in access to healthcare. And this came under the light and was reaffirmed during COVID, where we saw enormous differences in outcomes as a function of ethnicity and socioeconomic status. And those differences in outcomes are, for many, are multifactorial: decreased access to healthcare, poor or lack of health insurance, poor quality of care in some of these hospitals. Patients may have pre-morbid conditions, chronic conditions that are undermanaged and just managed in ERs, socioeconomic drivers, poor healthcare literacy, and increasingly exposure to ambient pollution, particulate matter, which we know can increase cerebrovascular disease, heart disease, and lung disease. Unfortunately, Black Americans have shorter life expectancy and per specific chronic disease have worse morbidity. And with respect to the over 1 million annual cases of VTE in the United States, Black patients are twice as likely to be hospitalized with pulmonary emboli compared to non-Blacks, and a 50% higher age standardized P-related death versus white patients. So here's a study from the Journal of American Heart Association from 2021, and it was examining how race may affect the severity of the pulmonary embolism and management and outcomes. And the hypothesis was that on presentation, the PE was more severe in Blacks than non-Blacks, and moreover was associated with decreased use of the kind of advanced therapies we've just discussed. Is retrospective data. It's from 20 hospitals in the University of Pittsburgh Medical Center, and it included something called the Area of Deprivation Index, which is a composite that looks at neighborhood disadvantage. Higher indexes associated with worse outcomes, and incorporates socioeconomic drivers and markers of deprivation, poor house quality, poverty, less employment, less access to education. And the outcomes were PE severity and outcomes. And let me just summarize it. And these were full about 7,500 whites, 1,200 Blacks, but then age and sex matched cohort, we smaller numbers, and we find that Blacks on presentation PE were younger statistically than whites with pulmonary embolism, and was associated with a worsening area of deprivation index and significantly worse comorbid conditions, CVA, diabetes, hypertension, COPD in Blacks compared to whites presenting with pulmonary emboli, and a higher incidence of prior clots. And in terms of outcomes, first of all, summary, PE were more severe in Blacks compared to whites. And with respect to any intervention, there was less intervention of intermediate risk patients, but paradoxically, more advanced therapies in Blacks and whites for high risk patients, and we'll try to dissect why that may be so. So here's just a graphic representation of the data. Number one, in general, Blacks compared to whites, they presented with PE. This is all the PE they presented, whether it be low, intermediate, or high severity pulmonary embolism. And then with respect to advanced therapies, and these are the treatment that was offered, procedures as a function of severity of pulmonary embolism. More treatments were offered to whites than Blacks, particularly intermediate risk, except high-risk patients, where more Black patients and white patients had advanced therapies if they were at high risk. So what did we conclude? We concluded that Black patients compared to white patients presented with PE were younger, had more severe PE, and had less intervention, except those at high risk of PE, with no difference in mortality. And presenting at a younger age than their white cohorts, we see this, that Blacks compared to whites present at a younger age with chronic medical conditions, including hypertension and strokes. Why did Blacks have more severe PE? Perhaps because of decreased access to healthcare and increased comorbid conditions. Why did Blacks have less intervention for intermediate risk? Perhaps most likely overt and implicit bias, and perhaps because the hospitals in their locale had fewer resources and less advanced therapies, except with respect to high-risk Black patients, they had more intervention than in white patients at higher risk. And how could one interpret that? And the study's author suggested maybe there's less discussion of end of life in Black and minority patients. So I'll leave that with you, and you all agree it's important data to reflect upon and act upon. So let's talk about length of stay in pulmonary embolism. It's not often we talk about it, but this is a recent paper which suggests a way of decreasing length of stay with a simple algorithm, which we could incorporate. Costs of PE management are up to 1.5 billion per year in the United States, and most of it is related to the length of hospitalization. We do know that length of stay is decreasing in pulmonary emboli patients and has gone down from 13 to 9.3 days, and that was 2013. And since then, we know it's even lower because increasing the use of DOACs, which facilitate earlier discharge. But it's still significant. So the authors of the study suggested that with accurate prognostication and an appropriate management algorithm, we could decrease length of stay. So it was a randomized control study. First of all patients were risk stratified in the ways we've already described, using a PESI score and the ESC, low, intermediate, or high. And then vital signs were taken, and the PESI score was calculated, the simplified PESI, which is 6 factors, not the 11 factors, which is the full PESI. If your simple PESI was 0, you were low risk. If your simple PESI was more than 0, then the authors checked biomarkers, and if they were elevated, an echo was performed. And hence, as you know, the patients could be defined as intermediate low risk if the troponin or echo was abnormal, or intermediate high risk if both were abnormal. And this is the management pathway. Please take a look at it and see if you think we can adopt it. So the control arm, routine practice, clinicians could do what they want. For the study arm, if you're low risk, the patients got out of bed the first morning. If you're intermediate low, the second morning. If the heart rate was normal and the O2 sat was over 90. If you're intermediate high risk, the patients remained in bed for 48 hours. There is no data supporting any of these recommendations. But what is interesting is the results that I'll show you in a minute. And in terms of discharge criteria, patients were discharged if they were normotensive, were not tachycardic, and had a decent O2 sat and pain-free. So the primary outcomes were length of stay, and the secondary outcomes looked at prognostic tests that were used, length of stay and mortality. Well, in those in the intervention group, the median length of stay was 4 days versus 6 days in the control group, with fewer prognostic tests ordered, and hence decreasing costs per patient. But no changes in mortality, importantly, or adverse events. And here we can see clearly that no matter when a patient was discharged, those in the intervention group, those patients who were part of that algorithm defining both mobility and discharge, they went home earlier than the control group. So using that simple management pathway, which admittedly I sped through, but it was quite simple. It reduced length of stay with decreasing costs. And similar outcomes that we worry about, 30-day mortality. So one could safely follow this algorithm, but reduce length of stay and costs. And perhaps we can deduce if length of stay decrease, then perhaps doing an inordinate amount of tests and excessive monitoring could be significant drivers of length of stay, which following the algorithm, we tried to minimize, the authors tried to minimize. And the study asks us to look at mobilization criteria, whether we should be adopting it, and discharge criteria, which are very simple. Low-risk patients out of bed first morning, intermediate low risk second morning, intermediate high risk bed rest for 48 hours. I wouldn't necessarily recommend that. I think patients looking okay could get out of bed within a day. And based on 2015 economics, one less day spent in hospital for PE is a $1,700 cost reduction. Limitations, they didn't look at high-risk patients or pregnant acute PE patients. This may be the last study, so we have time for questions, or maybe we have one more. And this is a terrific paper. I recommend you look at it. For all of those of you working outpatients, it's from the European Heart Journal 2022, which is actually a companion paper to a paper a lot of you are familiar with, printed by the same European Society of Cardiology, with a work paper on managing inpatients with pulmonary embolism. And it's a position paper with recommendations on the things we should be considering when we see our patients with PE who are discharged, and we focus on bleeding risk, particularly if we're going to extend anticoagulation, cancer screening, when to do it, is it useful, when to do thrombophilia workup, treatment of PE in women and pregnancy, and the role of oral contraceptives, issues with respect to lifestyle, activity, sports, and travel, the post-PE syndrome, which affects a significant number of patients after PE, and the concurrent increased prevalence of cardiovascular disease in patients who have PE. So first of all, bleeding risk. It's not something that we are all familiar with. We're familiar with bleeding risks when we look at AFib patients, and we have a way of risk stratifying their risk of clots. And some of us will use certain bleed map or has bled risk assessment tools to evaluate the risk of bleeding. With respect to the VTE population, there's an underutilization of risk assessment tools to identify bleeding risk. Some general comments. Number one, absolute contraindications to anticoagulation if your platelet count is low, and then you put a filter in and keep the platelet count greater than 30 to 50,000. What risk assessment tools are there that we could use to risk stratify a patient to risk of bleeding? CHEST has a risk assessment tool which incorporates 18 variables, which I'll show you, too unwieldy. The VTE bleed incorporates 6 variables, and it was derived and validated in 2 studies describing the use of a DOAC, a factor 2 inhibitor, versus Coumadin in these 2 studies. Low risk, less than 2, high risk, greater than 2, 2 or greater. And you'll recognize that some of the risk factors that were associated with increasing risk are very familiar to other risk assessment bleeding risk tools: cancer, hypertension, anemia, history of bleeding, renal dysfunction, increasing age. This is the CHEST 18 risks that are factored in, and from it, depending on how many risks you have, you can determine if the patient's low, moderate, or high risk, both for the first 3 months and for greater than 3 months if that patient requires extended anticoagulation. Let's look at cancer screening. There's a higher incidence of cancer in patients with VTE compared to age sex match controls without VTE, particularly at age over 50. And note, particularly if you have an unprovoked PE, up to 5% of these patients will have cancer diagnosed 1 year subsequently, compared to 1% who have provoked an obvious cause for their PE. So when in our patients, we see a patient with a spontaneous clot, should do routine labs. The patient probably has had a CT angiogram, which is good for cancer screening and could look at the liver and maybe the kidneys. And then one is recommended to use age and gender specific screening, cancer screening, as per current guidelines. Suspect underlying cancer in the patient who's had a PE, who's having a recurrent PE despite a therapeutic anticoagulation, or is bleeding GI or GU bleeding on anticoagulation. But please note, there is minimal evidence that early cancer screening is associated with improved survival. When do we do a thrombophilia workup? And a thrombophilic disorder is common in perhaps less than 30% of patients who present with a PE. But we should do it if it's going to affect management. And in particular, we could use it as a platform to discuss the risks and benefits of oral contraceptive and management of the pregnant woman and risk of recurrent VTE. One should consider anticardiolipin syndrome in a spontaneous clot, and it may represent up to 10% of unprovoked PE. And as you know, DOACs are not the way to go here. It's not evidence-based, but we rely on Coumadin. And consider anticardiolipin antibody screening if your patient has both arterial and venous thrombosis, has a history of a number of pregnancy complications. Now, with respect to women specifically in PE, what about the use of oral contraceptive? So in a woman on the pill who has a PE, you can continue the oral contraceptive if you need to reduce the risk of pregnancy or the patient has a history of menorrhagia. And understand, if you were to resume oral contraceptive in a woman who previously had a clot on the oral contraceptive, there's an increased risk of a recurrent clot. And in women who've had prior VTE, one should give them prophylaxis or even intermediate doses of anticoagulation. if they've had a prior clot while being on the contraceptive pill. What about sport and lifestyle? So general recommendation, if you have RV dysfunction with a PE, you should limit return to normal activity. And the European Heart Journal came up with this recommendation on amount of time you should spend per week in activity, either regular activity or higher intensity activity, to allow time for the RV to recover. And we're familiar with this with professional sports, men and women who develop VTE, particularly high contact sports. It's a very problematic. In terms of, and this is what I do and recommend it, in patients who are going on long flights, where there's a risk of immobility, and we call it economy class syndrome, where patients sit in tight spaces with flexed knees and a stasis of blood. Consider giving them a DOAC a day before, the day of, and for 2 to 4 days after travel for the outgoing and the return journey. And I guess this is the final slide. Post-PE syndrome is not uncommon. What is it? It's patients who still complain of shortness of breath and limited exercise more than 3 months after their PE. And there seems to be no other obvious explanation other than their recent PE. It is common. 40 to 60% of survivors of PE have post-PE syndrome. And it's not related to persistent thrombus, which occurs in 40 to 70% of patients at 1 year using new imaging techniques after their PE. And the patient may not have cardiothromboembolic pulmonary hypertension, which I'll derive in a minute. So the patient may have chronic thromboembolic pulmonary disease. These are patients who are symptomatic more than 3 months after the PE. You do an echo and the PA pressure is normal at rest. And you do a perfusion scan as part of ventilation perfusion scan or a CT angiogram, you still may see persistent clot, but they do not have pulmonary hypertension. The persistent clot may be a red herring, and you could do a cardiopulmonary exercise test, which may be pretty normal. It would not show what I call dead space ventilation, which would underlie that the patient was short of breath because they were hypoxic from increasing perfusion to poorly perfused areas from the persistent clot. The patient may have a panic syndrome. They may look, for many patients of the PE, it's a very traumatic event. It can be a life-threatening event, and it has its psychological scars. So psychological support and cardiopulmonary rehab may be a benefit. In contrast to the 3 to 4% of patients who develop pulmonary hypertension, and one looks for it when patients are symptomatic at least 3 months after their PE, their echo is abnormal at rest. You perform a VQ scan, which shows multiple VQ mismatches. And if the clot is proximal, and despite anticoagulation, these are patients who may be surgical candidates. And if they are frail, they may benefit from pulmonary vasodilators. And finally, always think about cardiovascular risk factors in patients who present with PE, because they are more common in patients with VTE compared to age and sex controls. So you should do workup, check their lipids, and inquire about family history, and counsel them with respect to smoking, and counsel them with respect to possible sleep apnea, which is a risk factor for pulmonary embolism. So we've talked about advanced therapies. I showed you that mechanical thrombectomy is a surgery with low risk of bleeding and short length of stay, that catheter-directed thrombolysis is superior to systemic anticoagulation conventional care on meta-analysis, admittedly. That heart rate is an independent predictor of mortality, particularly heart rates of greater than 100 to 140. PE response may not change mortality, but associated with increasing use of advanced therapies. I showed you a management pathway that may reduce length of stay. AI may help the radiologist and not replace the radiologist. Find this paper on outpatient management of the acute PE patient, and understand the importance of ethnicity and disparities in outcome as a function of perhaps decreased access to resources, both in the community and perhaps in the hospital too. Thank you for listening. Thank you.
Thank you so much, Dr. Steiger, for that incredible talk. We have about 5 minutes left. I know we have a lot of pulmonologists and budding pulmonologists on the call, so I will open it up to any questions that anyone may have. Dr. Berger, I see your hand raised. I'll throw it to you.
David, thank you very much. An amazing talk, really updating what feels like an area we're frequently updated on, but just so much great stuff. I guess my biggest question actually goes back to early in your talk, which is the sort of directed thrombolytics or thrombectomy. Seems like it's a little bit of a mixed bag there. Because the chest, their update to the last guidelines, right? Their second update, they came out against systemic, pretty strongly against systemic for non-massive hypotensive patients. And this seems like they didn't really, I looked and double checked, they didn't address directed catheter in those guidelines. But it seems like not only have we moved in that this is good for massive, but those submassive or non-hemodynamically changing events, but maybe where you are seeing right heart strain as we get better with imaging, realizing blood pressure is not the end all be all. There are effects before that. Do you think there are so I guess the question is, in the data, in those pooled analysis, as they're all sort of retrospective real life, were they only looking at massive or hypotensive, or had they already started looking at the submassive or non-hemodynamically or non-hypotensive patient? Because I would say that what we see is right heart strain that's probably hemodynamically significant, but not hypotensive.
Okay, all good questions, Alfred. So for the next 45 minutes, for the next 1 minute, all good questions. Number one, most of the patients who receive cath-directed therapies are intermediate risk. About 10 to 15% in all the studies are high risk. So they do include high risk, number one. And it does seem to be a benefit. But you would agree, Alfred, in someone who's in shock, giving a bolus or maybe a 50% dose of a bolus, either over 2 hours or just upfront, has been shown to cause a significant improvement in hemodynamics acutely, versus you're sending a patient to interventional radiology suite, monitored, maybe on pressors, and you're taking them for a cath-directed embolectomy. Fantastic procedure, and it works, but sometimes timing is everything. So whereas the evidence supporting thrombolytics, even for massive PE, high-risk PE, is not great. It's really not great compared to the cardiology literature. It's still recommended, but has a low degree of evidence. But my clinicians are on the front line more than I am. I think they would rather use that for most of their patients in shock than cath-directed. And again, the high-risk patients usually represent a minority of most of the patients who are described in the catheter-directed papers, studies.
So they're really looking at that submassive, the non-hypotensive.
Yeah, but it's still very relevant, Alfred, because as I laboriously kept telling everybody, those patients intermediate risk, the risk of death is from 1 to 18%. And until we can better identify which of those patients are on the precipice, and I think my colleagues are expert on echo, people like Jason on this call here at APD, who continually do the echoes on these patients. And looking for RV dysfunction. I showed you the echo on somebody with McConnell's. These are patients who fall off the cliff, those whose RV fails, and they're the ones you have to intervene aggressively. And then lactate as well, and BOVA, and all the other stuff I mentioned as well. That all helps.
Yes, thank you. It was really which patients are benefiting. So it sounds like the patients that are below, like what traditionally would have gotten full thrombolytics, are benefiting from this procedure.
Yes, some may, yeah.
Thank you, Dr. Berger. There's a question in the chat. I recognize that it's 1 o'clock, but Dr. Kwok asked, does obesity play in the discrepancy in the treatment and diagnosis of minorities minorities of pulmonary embolism?
It might do. It might do. Look, I think there's so many reasons why that study highlighted patients are getting inferior care. I think partly because a lot of the city hospitals may be under-resourced, and I think that could be part of the problem. But what that study showed us, and what we've learned, is that unfortunately the Black patients have a lot of comorbidities at a more advanced stage. And if you remember risk stratifying, looking in the PESI score, it incorporates a lot of comorbidities, CHF, diabetes, COPD. So we know there's a logical, partly logical explanation. But of course, what is not acceptable is the inequality in access to care.
Thank you, Dr. Steiger. I will give the last question to Dr. Matsuo So, our future interventional pulmonologist. Go ahead, Dr. So.
This is the mic.
He can hear you. So
Hi, Dr. Steiger.
Hi.
So here. So I was wondering, are there any data regarding the radiographical clot burden in relation to the decision of sending the patient to catheter-directed therapy, actively or pastly studied, examined already?
So if I understand your question, and it's a very good question, Dr. So, well, first of all, our radiologists know that proximal clot, central clot, these patients do better with, that's an indication for catheter-directed thrombolysis.
Okay.
More distal clot, catheter-directed thrombolysis may not be of significant benefit. Is that what you meant? And in terms of clot burden, there is a radiological marker called the Miller Index, which is an expression of clot burden. And we know that catheter-directed thrombolysis, before and after, there's a reduction in the Miller Index, which is clot burden. So that's an evidence-based manifestation of the benefit of CDT in patients with central clot. So it's a technique for patients with central clot. And if you follow the PER charts, you'll see when patients have more distal clot, radiologists are not enthusiastic about putting a patient through a procedure, which can have complications, where the overall benefit may not be any greater than using standard therapy.
I see. Thank you. Thank you so much. I just
Sure.
didn't know that part. Yeah.
okay. All right, it's 1:03. We are a little over time. I wish we had another 45 minutes to spend with you, Dr. Steiger, but thank you.
Thank you.
Thank you for your time, and thank you once again for letting us learn from you. Thank you, everyone, for joining us today, and we'll see you next week.
Thank you.
Thank you, Dr. Steiger.
Thank you.